but different one from another. So osteoarthritis from gouty arthritis, from psoriatic arthritis, from rheumatoid arthritis, from lupus arthritis, et cetera, et cetera, et cetera. Okay? And realize that what this is, and specifically when you have arthritis, it's inflammation in the joints. Now, some of your systemic rheumatologic diseases they're systemic because they affect the connective tissue. And so some of your diseases are called connective tissue diseases. Realize that your joints are held together by connective tissue. And so you're going to see some patterns. But where else is there connective tissue besides the joints? Heart, okay, good. Lungs.
What?
Pretty much every part of the body there's connective tissue. So realize that when we talk about next week about systemic rheumatologic conditions, they can occur anywhere throughout the body. So how many of you knew that rheumatoid arthritis can lead to pulmonary nodules? A few. Right? Absolutely. Okay. There can be skin presentations. There can be eye presentations. Uveitis, keratoconjunctivitis. You don't have to write all this down right now. You'll get it next week. You've got to think about where the connective tissues are. And so let's focus on some of those connective tissues. Now, when we talk about arthritis in general, okay, before we get to that, arthritis, it can be degenerative, which is a very descriptive term. Okay. It's when your joints break down, degenerate. And that can either be primary or secondary. If it's primary, it's inherent to what?
Joint, the joint.
Something or with the joint, the tissues themselves, those connective tissues. It could be a genetic defect. If it's secondary, it's from something else. So if you talk about arthritis per se, okay, and things that can affect a joint that you weren't born with, what comes to mind?
Age.
Injuries, I heard.
Psoriasis.
Yeah, that's what comes up at the top of the list to me as an injury to that joint. But yeah, you'll see that there are other things as well. And injuries can be mechanical. It can be metabolic, like gout. It can be so mechanical, metabolic, and even just old age or lack of use. That's degenerative arthritis. That can cause degeneration of the joint. Reactive, when you think of somebody who's reactive, a reactive personality, what do you think about? A response, is a friendly response? Not usually, right? If somebody's really reactive or overreactive, okay, it's a little bit excessive, a little over the top, a little extra, right? And so what the reactive arthritis is reactive arthritides are, is some type of inflammatory state, because we know it's joint inflammation, right? So it's an inflammatory state that's triggered by whatever the underlying condition is. Like, it's reacting to it. And then, of course, our systemic, which I said, these are typically autoimmune connective tissue diseases. All right, so we're going to start with osteoarthritis. Okay, and so this is the most prevalent form of arthritis. This is the old age arthritis, but you don't have to be old. Professor Rogers will have a hip replacement. Right, we don't have to be old to have a joint replacement. You know, and so. And old is all relative. But I prefer 60. It's really getting relative. And but realize that there is significant morbidity. Not necessarily mortality, but morbidity associated with arthritis. If I see somebody with really, really severe osteoarthritis. Jackson, what's your experience?
It's like PT. That's right.
Okay, so you saw a lot of them in PT. Yeah, absolutely. And so, pardon me? Gait, and difficulty walking, yeah, limping, and then maybe it starts in the knee, but what goes next? It's everything above it, right? Because it's all mechanical load. And so if you favor you're right, you walk in and you favor this, your mechanics are off instead of that nice smooth gait. And so now you're overusing other joints on that side and shifting it. People will often end up with low back pain, etc. And it's all because of a bad knee. And so there's a lot of morbidity associated with it. People can't function, they can't perform their activities of daily living, their ELs, they cannot do it. And so it's really about, it's just a slow, progressive destruction. And a lot of times, they don't really realize it until all of a sudden it gets to this breaking point. And so when you go into ER, near clinical, urgent care, whatever, you're gonna have somebody come in at 3 a.m. What brings you in? My knee, I'm having terrible knee pain. When did it start? 3 years ago. Well, what made you come into the ER today? I don't know. I just couldn't sleep last night because it was aching and throbbing so bad. Can't sleep. Okay, it's slow, but there's a breaking point for some of these people where they actually come and finally seek care. And at that point, a lot of times it's fairly end stage as far as a joint goes. And so what happens is as the joint gets destroyed, it starts with the cartilage. As the cartilage wears away, it's going to affect the bones. You end up, once you lose the cartilage, it's bone on bone. And it compacts, it rubs, and it creates an inflammatory response. And so, and yes, it can lead to significant changes in the bones. Can everybody see my poor little finger here? You see it? Is it straight? No, I don't have a straight finger anymore. That's my trigger finger too. Don't bend. It doesn't bend normally, but it doesn't affect. I'm still looking. But anyway, yeah, it makes significant changes and alterations. Classic evidence notes. For anybody who wants to see what evidence notes look like, I've got them. You can't miss them. And, you know, it does, and yes, sometimes it can be painful, sometimes it's not painful. Primary, intrinsic defects, either in the cartilage, mostly in the cartilage, but then is going to lead to that thinning, reduction in cartilage, narrowing of the joint space, ultimately that bone on bone, and it becomes very, very painful at times. Secondary, look at all your different kind of causes. Yes, it could be a congenital defect, maybe not in the articular cartilage or the connective tissue itself, but what if you have a leg length difference? Okay, if you congenitally have a leg length difference, it's going to affect your mechanics of ambulation, and that is going to alter your weight bearing load, and that is going to create unusual wear and tear. It can be acquired defects, torn cartilage, ruptured ACL that you never got repaired, etc. Okay, trauma, infection, some of your endocrinopathies, crystal deposits. So we're going to talk about gout and pseudo gout, osteonecrosis, which is your avascular necrosis, metabolic disorders, inflammatories. So there's a whole host of things that can cause secondary degenerative arthritis. Start with cartilage. If you remember what cartilage is, it is a very specialized tissue. There are chondrocytes within the extracellular matrix that are there to maintain the health of the cartilage. Okay, and all of that matrix that makes up the cartilage. So what's in the matrix? It's water, it's proteoglycans, it's collagen, and it's ground substance, which is, you know, kind of this very hydrated kind of semi-solid gel. Yes, is there hyaluronic acid and stuff? Yes, these are some of the things that are in there. The collagen is what gives it its strength, okay, and allows it to support those chondrocytes. Okay? And so it gives it the shape, the configuration, and keeps everything together. And the proteoglycans are there to allow for elasticity as well as stiffness. So give and take. It's a cushion. If you look at your knees, they are the shock absorbers of the rest of the body. Those cartilage in the knee are so critical for everything else above it. They take a lot of shock. And once that cartilage wears down, it's gone. Once you just pour it in chondrocytes, it's going to break down. So the pathogenesis of primary osteoarthritis. This is, you know, what happens in people without necessarily trauma is that those chondrocytes enlarge, they reorganize themselves within that cartilage matrix into the superficial part of the cartilage. And what that does is kind of like separates them, and so it makes them more prone to trauma as your shock absorbers are doing their thing. And so there becomes the cartilage itself, the matrix, becomes more edematous, especially in that intermediate layer. It's going to become more edematous. There's less cellular structures, and it's going to lead to more edema. Now, what do you think that that's going to do to the strength of the cartilage? What do you think it's going to do?
Weekend.
Weaken it, absolutely. And that's the next step. That weakens the matrix. Okay? And that can lead to microfractures, little teeny microscopic cracks that then allow that fluid to seep down in deeper and deeper. Okay? And so that synovial fluid is now going to leak down, and that's gonna widen the cracks, sort of like how a pothole develops in the street. Can start with a little crack, and then as it rains and the water seeps in and underneath and undermines, then a car goes over it. Now it's starting to break up into more and more pieces, and that pothole gets bigger and bigger and bigger. Okay, and it gets deeper. That's what happens in your cartilage. There is a defective repair process because the chondrocytes are now on the surface and they've been damaged. So they can't repair it. And so ultimately it extends all the way down to the bone. And as it becomes that big pothole, okay, now it's become to the point where you get bone on bone. And that's gonna compact that cortex on the end plate of those bones, gonna compact it, so it gets much more thickened and white. It can lead to, and that's your sclerotic changes. So you look for that surface being much more densely white with paleness underneath it, pallor of the bone. The synovial fluid can then leak into the bone and cause little cysts to form, little pockets of fluid in some of that subchondral bone. And as the body's trying to repair itself, the bones are trying to repair. Those osteoblasts are trying to repair it. They're, trying to lay down more calcium. That's when you end up with these big bone spurs, okay, or osteophytes. Sometimes they can break off and become joint mice, little flecks of bone within the joint, within the synovial fluid, which then, now you've got little pieces of bone that are sharp and are going to cause further damage. Looking at it diagrammatically, you can see on the outside, okay, you have fairly normal levels of cartilage, but as you start to see the edges, there's irregular. It's irregular. The surface becomes irregular. Just one more thing. Okay, so the surface becomes irregular. Here it's nice and smooth. It starts to get irregular. Here you start to see irregularities. Here it's worn away. Okay, and now you've got bone on bone. Once that cortex has been breached, fluid can seep in, causing those bony cysts. One there. And then as the bone's trying to repair itself, it starts to produce these bone spurs on the outside. Okay, on the edges, typically on the edges of the joints, often where ligaments attach. And those bone spurs can then, over time, depending on where they are, they can lead to damage of even the supporting ligaments, the supporting structures. Any questions on primary? Okay. Secondary, it's trauma. It's typically trauma is your number one, okay? Any kind of injury. And you can see it will follow this same process. But it's the injury itself that has created the initial deficit. Then that leads to what happens next. So if you tear cartilage in your knee, if you fracture your knee or your tibia or anything involving a joint, a lot of times it's simply cartilage damage. Doesn't have to be a full-blown fracture, but fractures that extend into the joint space, there's going to be damage to the cartilage. And so it just hastens the process a little bit more. As far as like repetitive impact loading, it can be vocational, like whatever your job is, versus, excessive running or not wearing good shoes when you run and just that impact. It doesn't even have to be anything aggressive. It can be just being overweight. Being overweight and increasing the weight-bearing load of your joints can, in and of itself, cause cartilage destruction. A lot of your orthopedic surgeons don't even want to start or attempt a joint replacement until patients have lost weight. Why? Because that joint replacement is going to fail. It's not going to help the patient. And it makes their rehab 10 times worse. And that's an underestimate. Okay, so even immobilization can lead to cartilage atrophy. You need weight-bearing exercises, load-bearing exercises to maintain the health of your cartilage and keep those chondrocytes active. Otherwise, they become senescent, just like our white blood cells. You don't use it, you lose it. So if you have somebody who's been immobile, okay, you need a very gradual return to physical activity. Because if you go gangbusters right off the bat, it can actually cause more damage. Because the joint's not prepared for it. Don't think that you can tell your 300-pound patient, you need to go exercise. You should go consider, moderate. The current recommendations are moderate to, moderate impact exercise for 20 minutes, 5 times a week. You got to start low and go slow. Let's do swimming. Let's consider aquatic therapy first. Let's get some of the weight reduction down. Let's start at a point where, and then progress them. You start walking before you run. I don't expect those patients who haven't been doing anything to just all of a sudden go out and start running around laps around the track or on the treadmill. It's unrealistic and you're setting them up for damage. All right, what are some of the manifestations? I have seen pretty much everything. I have seen hot joint effusions, a red hot joint from osteoarthritis. Did I know it was osteoarthritis? Could it have been gout? Could it have been a septic joint? Absolutely. Got to tap it. Got to stick a needle in it, drain the fluid off, send it to the lab, and find out what you're dealing with. Because you don't want to miss a septic joint, and nor do you want to miss gout and treat it inappropriately. But that's not the norm. Okay? It's not the norm. The norm is, this kind of long, chronic, aching pain. It's worse with activity. It's better with rest. stiffness of the joints until you get it up and get moving, okay? And the classic theater sign, put the theater sign in, I got that too. Go to sit down, you sit for about, and 2 hours in class, and you gotta get up, and then they gotta go like, oh, they gotta push themselves up. They've been sitting so long, and then they kind of like gotta get their feet under them to get moving again, because they're so stiff. And so, but as it progresses and as the joint worsens and worsens and worsens, yes, they will have pain at rest. It's not the classic presentation, but it tells you it's further down the road in the process. So there's pain at rest. There's pain with use, after use, and that's symptoms of much more significant joint destruction. Okay, they can have joint crepitus, they can have really, really severe pain with mobilization of the joint. Okay, and yes, it can have an active synovitis, an inflammatory joint effusion. Okay, look for joint deformities. Yes, ligamentous disruptions, which can lead to subluxations of the joints. You can have Heberden's nodes, as I have. Bouchard's nodes. Heberden's are the PIPs, DIPs. The Bouchard's nodes are the PIPs. So B comes before H. Yeah. These are some of your classic joint manifestations, and you can read through these. These are how they might present, looking at different joints throughout the body, cervical spine versus lumbar spine, hip, knee, etc. Looking at the images, okay, there's typically asymmetric joint narrowing. Okay, one side's going to be affected more than the other. So because it's usually a matter of wear and tear, uneven loading, it's the side that's affected more, okay, that is going to wear out first. If you have a person who's knock-kneed, okay, or they, their knees come in and they bend, they have that kind of valgus, genu-valgus, okay, where are they going to wear first?
The medial side.
Medially, right? Okay, so if they're bent this way, actually laterally, but you don't know. It could be either way, but you look at them and they're wearing abnormally. If somebody's bow-legged, they're probably going to wear more laterally. Medially, I think it's more medially. I don't know. I can't remember. But you will see it. And you'll start watching people and you'll be like, oh my gosh, okay, like that person's gonna have terrible arthritis. You can just start looking at how people walk. But people who have pes planus, okay, so they have flat feet. Okay, they walk like a dog and they slap their feet, or they have really flat feet. When you have flat feet and you pronate, if you don't support those arches, where's the stress load gonna be next? Where? Medial or laterally? Medially, right. Medially, right? So those are the things that you look at. Okay, if somebody wears the outsides of their heels of their shoes, and they walk that way, it's probably going to be more lateral wear. Okay, realize that this can also occur between the patella and the femur. And you're going to hear about the Q angle of the hip and all that good kind of stuff. Women have a wider Q angle just because of childbearing and the shape of the pelvis. You learn about the different shapes of the pelvis in an AMS. Okay, if that sets the groove for where the patella rides over that patellofemoral groove. Okay, in walking and climbing stairs, etc. If the angle's more acute, then it can cause that patella to track more laterally and ride over that lateral femoral condyle which is gonna wear away the cartilage on the undersurface of the patella, leading to patellofemoral syndrome. Okay, and what they call it, patellofemoral okay? Gonna wear away the cartilage. You can see subchondral sclerosis, you can see the osteophytes, and you can see bone cysts. So in this particular, this is your nice normal knee, and you see pretty even space between. I would say that this might be a little bit early arthritis because it seems to be a little bit more densely white or sclerotic appearing. But when you look at this knee, can you see the asymmetry in the joint? Okay, you can see this, you look at the spacing. These are your nice tibial spines for attachment of your ACL. Here, can you see the asymmetry? Pretty clear, isn't it? Significant asymmetry. And if somebody's walking like that and wearing that medial aspect of the knee down, look at what you see. You see loss of joint space, number one. Okay, so you got lots of joint space. You don't get that nice clear area. Okay, and you don't see that nice, this is bone destruction. Okay, there's little bubbles in there. You got some bone cysts that are occurring. Okay? And you can actually fracture off pieces of that tibial spine because of shifting and laxity in the joint. So you lose that nice space, you're lost cartilage, you get bone on bone, you kind of get this inflammatory picture where it's much more cloudy, and you get dense, sclerotic looking bone, you got a bone spur on the side. That's classic osteoarthritis. Looking at the digits and some of the, again, Heberden's nodes are on the DIP, Bouchard's are on the PIP. But you can have significant deformities. Imagine buttoning a shirt. Okay, with fingers like that. It can severely affect, you know, the top right, you can really see the deformities there. The bottom right, you can see Bouchard's nodes, especially on the index and middle finger, ring finger. You can see those little nodules on either edge of the joint. And these get very hard. They can get pretty big. And that's just another sign. Any questions on osteoarthritis? Any questions? Makes sense, right? Pretty practical. All right, so let's move on to the crystal-induced arthropathies. And the gout is a very common occurrence. Okay, that's probably your more common one. Yes, it's called gout or gouty arthritis. It is an inflammatory arthropathy. Okay, and it's typically caused by metabolic dysfunction leading to crystal deposition in the joint. Okay. People will actually describe it as it feels like I'm walking on glass. Feels like there's glass shards in my joint. And if you think about what a crystal is, you can see why. And that crystal, those crystals will destroy the cartilage. And they will lead to all of the inflammatory findings that we just saw, even with osteoarthritis. Okay. In gout, it's specifically uric acid crystals or urate crystals. In pseudo-gout, it's calcium pyrophosphate. They have different shapes. You can tell the difference under a microscope. And pseudogout is also called chondrocalcinosis, right? And this is a very descriptive term. What does it mean? Chondrocalcinosis.
Cartilage calcification.
Right, calcification of the cartilage, as opposed to uric acid floating around in the synovial fluid. Okay, so one, you see the deposition actually in the cartilage, and you can see whitening of that cartilage. So, gout itself can present in a lot of different ways. Anybody know the most common location for gout?
Big toe.
Okay, it's the first MTP. Okay, so it's the first MTP or the MTP of the great toe. That is the most common site. I've seen it in the MCPs. I've seen it in the wrists. I've seen it in the elbows. I've seen it in knees, ankles, toes. So yes, I've even seen it in the tarsal bones. And so what happens is typically there is a problem with purine metabolism that leads to excessive uric acid accumulation. Okay, and when the hyperuricemia occurs, it has the potential, doesn't mean it's going to, but it has the potential to precipitate out as crystals. Just like other stone diseases, crystals deposit when you have high solute concentrations in your solution. So can dehydration affect gout and precipitation of uric acid crystals? 100% yes. Okay. So our treatments are at lowering uric acid levels and keeping a patient hydrated so that you don't have that high solute in your certain solution. Almost 3/4 of your patients are going to be male. Definitely a male predominance. And we see it more in the Black race than we do in any other race. It's just more common. We see it more between the ages of 40 and 60. I will tell you that my stepson had his first gout attack when he was in his 30s. But he liked his beer. It does. Okay. A third of the cases are primary, meaning that it comes from their genetics and their ability to metabolize purines. 2/3, so the majority, are secondary. And so what are some of those? Use of thiazide diuretics. How many people do you think are on HCTZ by itself or in combination? What? Okay, so it is a risk factor. Never forget that. No medication is without potential side effects. So thiazide use, tumor lysis syndrome, chronic renal failure. Those are some examples. It's not an exhaustive list of what can cause gout. Hyperuricemia alone does not mean the patient is going to have gout or gouty arthritis. Okay, and I will also tell you that gout can occur with a totally normal uric acid level. So getting that uric acid level is not always diagnostic. And so, and the disease itself ranges from the arthritis itself to what we call tophaceous gout, where there's clusters or clumps of these crystals. Okay. Topha. That then float around and cause even more destruction. They can deposit in your soft tissues. To uric acid deposition in the nephrons in the kidney, leading to nephropathy. And even kidney stones. So there's a pretty broad spectrum of how these patients present. Okay, again, pathogenesis, it starts with purine metabolism. Okay, especially primary. And well, overall it is. So there are two different pathways and by which purines occur and uric acid is made, right? There's what they call a de novo pathway. Purines get synthesized from non-purine precursors. And there's a salvage pathway, right? And where the purines are a breakdown of nucleic acids, either from diet, which is relatively common, or endogenous. That's where like tumor lysis syndrome comes in. Okay, so if you're breaking down your own cells or your patient undergoes chemotherapy and we wipe out all those leukemia cells, it's going to release uric acid, essentially, purines from the nucleic acids, which then become your uric acid and you get hyperuricemia from those nucleic acids. Okay, otherwise it's rich meats, red meats especially, and that's where we get a lot of, it's digested, it's food that we take in. The hyperuricemia leads to either overproduction of your purines or increased salvage. They're not able to break them down, or augmented breakdown. Or in the case of chronic renal failure, it's a decrease in excretion. So if you can't filter and you can't excrete because your kidneys, your GFR is only 30, then it's going to accumulate in the bloodstream. So this is diagrammatically the pathogenesis of it. It starts as, you start with your precursors and either you have the de novo production in your body, or it's a defect in your salvage or excretion. And those are that's your pathways for increase in uric acid levels. Okay. All right, now what happens? So you have high uric acid levels. And we say, well, that doesn't always mean the patient's going to have gout. No, it doesn't. Okay. Sometimes the uric acid will precipitate out. So hydration plays a role, renal function plays a role, temperature plays a role. Okay. But in gouty arthritis, that's when the uric acid is going to precipitate out into the joint, into the synovium. And we'll talk about that in a minute. Once you have these crystals in there and multiple crystals, high concentration, the more there are, the more they're going to collect into these tophi. And that's going to collect into the synovium and cartilage. And think about crystals, about salt crystals. Think about that within your joints. Okay, it's going to activate complement. Complement's then going to draw in your other white blood cells, especially your PMNs, neutrophils. Okay, those are going to try to phagocytize, okay, some of the crystals, and you're going to have death of your neutrophils, It's gonna lead to cytokine release, more cytokines, which then creates the inflammatory milieu. Okay, which then starts to, is non-selective and will start damaging chondrocytes and other structures within the joint. Okay, and lead to joint destruction. These are, yes,
Kofi.
Kofi, that's where you have like a big collection of those crystals, almost like a rock.
Like, well,
It's like a rock or a stone. Okay, and that's what this is a picture of, believe it or not. Yeah, these are how, this is how the Kofi, there's uric acid, they'll collect and they'll form these big, painful, inflammatory lumps under the skin, in the soft tissues, usually around the joint. And so they can be, in this particular case, the one up in the middle finger is actually ulcerated. And the lower picture shows a cross section of the actual joint. So this is the bone here, part of the bone. And all this white stuff is just deposited tophi, or uric acid. So here's your bone here. All this white stuff, all that is tophaceous gout. It's a collection of those uric acid crystals. Yeah. Impressive, isn't it? So there are 4 clinical phases. That asymptomatic hyperuricemia, okay, is typically asymptomatic. It's called asymptomatic. Yeah, the uric acid levels rise in the blood. What happens next is very patient dependent. Okay. The second phase is when it does precipitate out and they get the acute attack of gout. And, initially, it only involves one joint. That first MTP is the most common. And the interesting thing is that it often occurs at night. So this patient will go to bed and then a couple hours of sleep, it just starts aching and thumping. And next thing you know, it feels like it's on fire to the point where they can't even stand. One of the classic descriptions is they can't even stand the bed sheet to touch it because it's that inflamed. And it happens within hours. Like it goes from 0 to 60. And it can be precipitated by a lot of exercise. Why do you think that is?
More metabolism.
More metabolism and dehydration. Thank you. Okay. So less solution, more solute equals precipitation. Okay. Certain medications. Ding, ding, ding. Diuretics, especially HCTZ. Okay. Foods. Hello, more purines that we just ingested. Alcohol, especially beer. More purines, brewer's yeast, okay, precursors, or dieting. Okay, and so those can often precipitate it. Then there's a remission period, what they call intercritical gout. And that follows the acute attack, waiting for the next one to occur. And then over time, with recurrences, there can be this chronic tophaceous gout. And that's usually after about 10 years of recurring bouts that you will start to see those kinds of nice, nasty lumps starting to occur. Okay. Realize that, this is linked to cardiovascular disease. But if you look at the diet and what foods, et cetera, are higher in your purines, all of this is gonna make sense. All right, why does it precipitate out at night? Anybody? Basically, good answer.
Your urine production slow down, so then you're not excreting it.
Okay, so less renal excretion of it. Why the big toe? Why the first MTP? At night? Pretty fascinating, really. Does anybody remember about urine and like when you collect urine and you do urine testing? What happens if you leave the urine lay around for a while? Yes, crystals can precipitate out. So what happens at night is when your patient is supine, you're not urinating, okay, you're filtering some, but metabolism slows down. And now it's the furthest from your heart. It's the coolest, has the coolest temperature. And yes, maybe some stasis. But at that point, the colder temperatures in the periphery are what lead to the crystal precipitation in the big toe. Temperature. Ray knows. Good. Pretty neat, huh? Makes sense. All right, so again, hyperuricemia alone doesn't mean somebody's gonna have gout. We test the fluid, draw, it's all hot, red hot, swollen, you don't know what's going on. Patients never had this before. You can do a serum. You gotta match your clinical picture with your labs, okay? You think it's septic, you think it's a diabetic patient, are you worried about it being a septic joint? Yeah, I would be. Okay, so you draw a CBC. White count might be slightly elevated because of pain. Okay, but you look at your differential. If it's septic, what would you maybe expect in your white count? Left shift, it's gonna be high, yeah, it'll be high, but it can be high because of pain. We don't know for sure at this point, so let's look at the differential. Septic, expect a left shift. Inflammatory, gout, probably not gonna have a left shift. Okay, probably have a normal differential. Make sense? If you stick a needle in it and aspirate, do an arthrocentesis, you send the fluid to the lab, you can check it. You check the pH, you can check the glucose level, you can check the protein level. Okay, you can have them look for crystals. You can do a gram stain. Now, with gout, it's negatively birefringent, needle-shaped crystals. Those are the buzzwords that you need to remember for gout. Okay. And so it's actually, ideally, we want to alter the diet, keep this from happening. We treat it acutely. NSAIDs are typically, unless they're contraindicated, those are your go-to drugs. Indomethacin, 3 days of indomethacin, 75 milligrams. It's gonna, they feel better within 2 doses. It's very, very effective. Ibuprofen will work. Indomethacin just seems to work better. And it works via prostaglandin inhibition. Colchicine used to be the standard treatment, however, they would take colchicine until they developed the side effects of colchicine, like diarrhea, and then they would slow down their dosing, so they would take it, it's ridiculous, but there's a lot of side effects with colchicine. You could still use it if somebody's, NSAIDs are contraindicated. But that inhibits your, neutrophil migration and leukocytosis, so it decreases some of the inflammation. And then, of course, we can do intra-articular steroids to suppress the immune response. But I tell you what, you try sticking a needle and you've already got a red hot swollen joint, it's, stretching at and all that stretch and the pain receptors, and now you're gonna inject more fluid via, steroids into a joint. Your patient's gonna hate you. I have to tell you that right now, they will hate you. Plus, it's not that easy. It's not, it's especially on a small joint like a toe or a partial joint or even an MCP joint. So, do they use systemic steroids? Yeah, sometimes they can. If everything else is contraindicated, you can go to systemic steroids. Just beware that systemic steroids have all that baggage and adverse reactions. So in some of your patients, you have to address the hyperuricemia. Dr. Noel will talk about this in detail. Allopurinol, it can actually, it inhibits your, one of the breakdown, one of the enzymes that cause the uric acid production. And febuxostat is gonna inhibit it the same pathway. They both work on the same pathway. Your uricus, like probenecid, prevent the reabsorption and promote excretion of uric acid. So they work on the nephron itself to make sure that any uric acid that gets filtered through the glomerulus gets excreted in the urine. That's how they work. All right. Okay, we'll finish these two and I'll give you a break. Pseudogout, which is your chondrocalcinosis. Okay. These this occurs often when there are already osteoarthritic changes. Okay, and cartilage degradation. So sometimes in the early stages of your middle stages of osteoarthritis. And so what happens is you get shedding of calcium pyrophosphate crystals into the joint cavity, and it's into the cartilage. And those calcium pyrophosphate crystals will now cause inflammation in the synovium. Most of the crystals are in the cartilage proper. And once you have crystals that have infiltrated into that cartilage, it's going to just further degrade that cartilage and rapidly increase the joint destruction to arthritis. Right? When you look at these crystals, they're rhomboid shaped as opposed to needle shaped, and they're only weakly positively birefringent. So when you look at them under a microscope, the one on the left are your urate crystals, okay, which are needle shaped, and you can see depending on which way they line up with the light, they can appear yellow or blue. And your calcium pyrophosphate on the right side, you can see that those are more rhomboid in shape and only weakly positive birefringent. So they turn blue when they're parallel. Okay. All right, gout versus pseudo-gout. The one on the left, where's the problem? The feet. What's the problem?
First down to.
First MTP, there it is. There's first MTP, okay? What do you notice? What do you notice? Tell me about the soft tissues and tell me about the joint itself.
Joint degradation.
Go ahead, Aisha. Okay, so you see all kinds of irregularities in the bone. Okay, so you see, describe what it looks like to me. Chewed up, like very irregular. Do you see joint space? Do you actually see a nice space between the metatarsal and the proximal tarsal? No, it's completely destroyed. The joint itself is completely destroyed. Okay? A lot of irregularities in the bone. Okay? And what's happening in the soft tissue around it? Okay, so if you're looking at this one's greatly more affected than that one, but both of them, you have no joint space like you have on the other ones. The joint itself is completely destroyed. You have a lot of irregularities in the bone. Tell me about that. Michelle?
It's trying to repair itself.
Maybe, or what else could it be? At this stage of destruction, what would you expect?
Like inflammation that's like calcified or like.
Calcified or it's
More like curators.
tophaceous. Okay? So it's those uric acid deposition, tophaceous gout. So that is classic gout. Okay? Is that the only joint that's affected in this image?
No.
Eric?
So I just have a question.
Okay, I'm gonna get my question answered first. Is that the only one that's affected? The MTPs? The first MTP?
The DTP,
Which one?
the first one.
Okay, first DIP on the right foot, definitely. Anybody else? Second DIP, PIP. Okay, on the right foot. How about the left foot?
Second one.
Second, PIP. Okay, so you can see that it is involving other joints as well. Very good. Erin, your question, please.
Oh, in the profile, or into the.
Not that I know of. No. Not that I know of. I mean, any kind of chronic inflammation, you need to, probably. But, osteosarcoma, I've never seen it. It doesn't mean that it can never happen. All right, tell me about the knee. Tell me about the knee. What do you say? Is there good joint space? Cindy says yes. Good joint space. Okay.
Just sclerotic.
It is sclerotic, okay? So you see this dense white, that's sclerosis. Good. So what does that lean you towards?
Calcium. Arthritis.
I know, but what disorder?
Osteoarthritis.
Osteoarthritis. So what else is associated with osteoarthritis? Spurs, okay. Do you see any? Maybe a small one. Right there. Could be bone spur, but it could also be. We're talking about crystalline arthropathies. All right, is your cartilage nice and clear? What does your cartilage look like? Is your cartilage nice and clear? It's nice and clear? No, it's cloudy, right? What turns things white? Calcium. So, calcium pyrophosphate, this is pseudo-gout, calcium, whatever it is. Pseudo-gout. Undercalcinosis. Okay. You can see that the cartilage has been, there's deposits in there, and that is associated with osteoarthritis. So, all right. Take a break, and I'll see you in about 10 minutes or so. I'm sorry. Okay, and these often affect the spine, but they can affect other joints as well. So these are an interrelated group, okay, of multi-system now. So they can have other effects, but it's primarily affecting the axial skeleton aspect, particularly the spine, okay? So they can still have some other effects. So take psoriatic arthritis. What other system is typically involved in psoriatic arthritis?
Skin.
The skin. Very good. See, so that's what I mean. But when we're talking about the arthritis component of it, keep in mind that we're talking about especially the axial skeleton. Okay. In all of these seronegative spondyloarthropathies, the inflammation typically begins either at the tendon or ligamentous attachment. This is very different from the cartilage and synovium. Okay. So other connective tissues is where the inflammation starts. So think tendinous and ligamentous attachments. Sacroiliitis. Sacroiliitis, that's your SI joint. Okay, that is a very classic hallmark of these disorders. So people will complain of low back pain, and they will have painful, tender, palpable SI joint pain. And yes, it can still involve the peripheral joints. But they're seronegative for our rheumatoid factor. We don't always know the exact pathogenesis. But these, especially ankylosing spondylitis, have a strong association with the HLA-B27 gene. Okay. So we'll start with AS, or ankylosing spondylitis. This is your bamboo spine. Okay. Everybody knows what bamboo looks like, right? So I'm going to go forward a minute. And what you end up seeing is a spine that progresses to almost look like a piece of bamboo as it all fuses together ultimately. So we're going to get there. Okay. And so AS is chronic. It's systemic. It's inflammatory, involving SIJ, there's that hallmark, SIJ, and your vertebral column. And the spine becomes progressively more and more stiff, Why? Because you get this inflammation that's gonna lead to calcification along those supporting ligaments that then is gonna, as it gets calcified, it's gonna, they're gonna lose their flexibility of the spine. Happens more so in males than females. Okay, in the female, it tends to be a little bit slower in onset and not quite as severe as in males. And usually this starts in late adolescence and progresses into early adulthood. If there is the potential for later onset. Okay, and if it's the later onset, it often will tend to involve more of the C-spine and peripheral joints. Ultimately, there are bony erosions where those tendons and ligaments attach because of the inflammation and the degradation of the inflammatory response, those cytokines and, and inflammatory cells that they have on those areas. Okay, it often will begin at the SIJ and move towards the head. So starts low and moves towards the head. And those the vertebrae become very squared off, boxy, and then essentially fusion because of the inflammatory response leading to that movement called the bamboo spine. Okay. Yes, it can involve the larger peripheral joints. We don't know the full pathogenesis of it. And what we do know is there are a lot of monocytes in acute disease when you look at it histologically. And 90% of the cases do have an HLA-B27 antigen. Okay, so against your gene or that particular immune reaction. So two theories for it: that the gene for HLA-B27 antigen can be linked to other genes that then determine what happens, or that lead to susceptibility to infections or environmental agents. And these are human lymphocyte antigens or leukocyte antigens. So that's specific antigens on the surface of the white blood cell. Or it's an autoimmune reaction to some other kind of antigenic determinant in the host tissues, usually in response to some type of infectious agent that triggers it. So maybe molecular mimicry, but the bottom line is we really don't know. We really don't know. So what do we know? We know that it's related to HLA-B27. We know that there are monocytes present. And these are kind of your clinical manifestations, which you'll learn in Clin Med. Okay. And over time, as the back becomes stiffer and stiffer and stiffer, they're going to lose the natural curvature of the lumbar spine. It's going to become very flat. Then that's going to trigger changes in the thoracic vertebrae, leading to kyphosis. And then they get extension of the neck. And so ultimately, okay, they're going to start like, this is kind of the progression of your deformities. Okay, starting, you can see where you have a nice curvature all the way to in 1947 of the lumbar. That flattens out. You start to see the increase in kyphosis. That and then the patient becomes more and more bent over appearing. Okay. And then we can go back and talk about some of the other changes that occur because of that kyphosis, because of the changes and the restriction, even in rib movement, because of the fusion of the spine and the involvement of those ribs, it's going to restrict expansion of the thoracic cage, which ultimately leads to cardiac and pulmonary restriction. So their exercise tolerance is going to go way down. Okay, that the loss of lordosis and increase in kyphosis as well as neck extension is going to affect their mobility and their mechanics, which ultimately will affect other joints. And it is associated with an anterior uveitis. And that can even be the initial presentation or can occur at any time during the course of disease. Sometimes they can have fever, malaise, fatigue, fatigue being the most common of those symptoms. And yes, it can lead to osteoporosis over time. Because they're not using it, they're gonna lose it. No exercise tolerance. So looking at some of the imaging, okay, the pelvis, what we're really looking at, if you look at the SI joints, okay, your sacroiliac. Okay, actually that's showing, yeah, sacroiliac, because that's your sacrum there, there's your iliac crest. And if you look, you have no joint space and it's very, very, cloudy appearing, if you will. And this is all inflammatory changes involving those joint spaces. Here, it's completely obliterated. You see a little bit of joint space there, but you can see that it's just very, very densely white and irregular. That's a close-up on your SIJs. As you go down to the lower left, you can see in the lower part of the spine, you can really start to see the boxing, okay? And you can see the bridging that's occurring and fusion, okay? And you can start to see the bridging between those vertebral bodies. Okay. So here, very boxy appearing. This part's fused, this is fusing, okay? These are all connected at this point. You've got inflammatory changes in there, and it's progressing in that caudal to cephalad direction. And these are just some other images, MRI, which show some of those same changes. Okay, so that's your imaging. Okay, it's diagnosed. Your history, physical, imaging. There are labs to rule out some of your other arthropathies, okay, especially in the early stages. Your SED rate and CRP are typically elevated. And the HLA-B27, because it's associated with so many other different pathologies, it's not diagnostic by itself. You often need these imaging, etc. Okay, and that just summarizes your treatment. So ideally, you try to keep them moving and maintain ideal body weight. If they're smokers, you want them to stop because that's going to compromise their lung function even more, et cetera, et cetera. Right, so that's AS in a nutshell. Reactive arthropathies. These are very, very interesting in that if you're going to have a patient who presents with a painful swollen joint. And it can be red or it cannot be red, but it's typically a painful swollen joint and you're like, what's going on? But you draw the fluid off, okay, and they are gram stain negative as far as organisms, they're culture negative. Okay, you can culture them all you want, they're going to be negative. And so the joint fluid itself is sterile, but you have inflammatory cells present. And typically, this is going to be, it may not be, it can be distant to, let's say they had a URI. They could have a tick bite, they could have Lyme disease. Okay? Lyme disease is a reactive arthropathy. Okay? And it has to do with inflammation and just whatever the body does. And so there are there's multiple categories, including urogenic, enterogenic, so they could have a GI issue. And, after the GI issue's over, their knee swells up, it becomes painful. Like, oh my God, is this a septic joint? And no, it's not, it's culture negative. And so we think it has to do with overactivity of your natural killer cells. And so we see this even with HIV or AIDS because it spares the natural killer cells, the target is the CD4, CD8 cells. And so you may actually see this more commonly in those kind of patients. The patients with that disorder specifically, because of that's where they think this problem lies. Okay. Yes, it can be caused by bacteria. It can be caused by environmental exposures, including silicone. It can be, caused by viruses. It can be caused by, you don't even know. And so bottom line is we attach this to, we attach this to joint inflammation that is a result that essentially cultured sterile synovial fluid. So if you take Reiter syndrome, okay, Reiter syndrome is a great example of a reactive arthritis. Okay, it's typically due to chlamydia. But does the chlamydia get to the joints and cause the joints to flare up? No, it's not like the gonococcus, which can cause a septic joint. Chlamydia is not. It causes a reactive arthritis. So you can tap all the joints you want, but they're going to be negative. But it's a result of chlamydia infection, chlamydia urethritis or prostatitis. And so, and of course, Reiter syndrome, you have the conjunctivitis, the can't pee, can't see, can't climate trade. So you've got the urethritis, arthritis, conjunctivitis. And so you treat the underlying infection and the arthritis clears up. And so, yeah, whatever reason. And we don't know the exact patho on this. All right, psoriatic arthritis is also a reactive arthritis. As you know, psoriasis involves the skin. It has to do with T cells and inflammatory changes related to T cells in the dermis, epidermis. Okay, and so your RF, your other systemic markers are going to be negative. It only occurs in about 7% of the people who have psoriasis. So it's not as common. There is a commercial on TV right now with the guy showing that he has psoriatic arthritis. And, but they can present with a spondyloarthropathy. So it can present with the sacroiliitis and back pain and stiffness. It can present as almost like rheumatoid-like. So, which you'll learn next week, okay, with a lot of big synovial inflammation, or it can be a combination of the two. They can have both, axial skeleton, SIJ involvement, as well as peripheral joint involvement. And again, don't know the exact pathogenesis of this, and probably is multifactorial, including, patient genetics, environment, potentially trauma. But T cells, just like in the skin, seem to be implicated in the joints as well. Why it affects some and not all, we don't know. Yes, Michelle.
The synovial fluid that you sample from these, it's not gonna be bloody or anything.
It's not going to be,
It's not gonna be bloody.
no,
Okay, so that's how you would distinguish it between like a reactive arthritis versus like osteoarthritis that's like.
No, neither of them should be bloody. Neither of them should be bloody. Okay, you'll have white cells. And in this particular case, you'll probably have, specifically T lymphocytes or lymphocytic infiltration. However, they're not gonna be culture positive if you culture them. Okay, or gram stain positive for any organism. You're not gonna see gram positive cocci or gram negative rods. You're not gonna see those. Right, but typically it's straw colored fluid. If there are a lot of white cells, it may appear a little bit cloudy. More purulent, but it tends to be just straw colored. If it's bloody, it's because it was a bloody tap. It's a bloody arthrocentesis. Okay, the only reason you should have a hemarthrosis is, the main reasons for a hemarthrosis are clotting disorders, a coagulopathy, where you're not able to clot, like hemophilia, or trauma. For diagnosing this, you need both skin and joint involvement, and there are 5 different subgroups of psoriatic arthritis. And so symmetric makes up the majority of the cases. About half of them are going to be symmetric. So you're going to see it on both sides of the patient. Asymmetric is going to occur about 35% of the time, and it tends to be milder. The spondylitis part involving the axial skeleton is another version of it. DIP inflammation is another version, and then mutilans is the most severe case, and we only see that in about 5% of the patients. So there are 5 subgroups of psoriatic arthritis. Okay, and tends to be pretty slowly progressive. It'll have better outcomes than rheumatoid arthritis. However, you know, we still are going, the treatment these days is some of these biologic agents that then slow your halt your T cells and prevent that T cell infiltration of your joints. And so it is somewhat of an immune suppressant and can lead to, some opportunistic infections. Okay. Typically your NSAIDs and other DMARDs, which we'll talk about, are disease modifying agents for rheumatoid disease. Those are your mainstay of treatment. However, the TNF inhibitors, the biologic agents, are really being used more and more often. And you'll learn more about the clinical management of it in ClinMed. So this shows you some psoriatic arthritis. Okay, and one of the classic findings for psoriatic arthritis, especially involving the peripheral joints, is this pencil in a cup deformity. So it looks like a sharpened pencil point. It causes these weird peripheral erosion, and then it's sitting in the cup, and kind of upside down, and the cup sitting on top of it. So if you look over here, that's kind of your old-fashioned pencil sitting in a cup, and that's one of the classic deformities. You can see these. Here's a bone erosion here. You can see. Yeah, so anyway, you can see these kind of changes, but that classic, if you ever see pencil in a cup, think psoriatic arthritis. If you're looking at the hand, which hand has the pencil in the cup deformity? Is it right or left? Right, okay, which joint? Middle finger. Okay. Right side, middle, which joint has it? There. Okay, so your
It's the left
MCP.
side.
MCP has it.
The one right above it.
Well, I don't know how
Yeah.
to do that.
And then that's the other.
Mhm.
Well, whatever, it's this one, right there, okay.
I know.
Maybe the start of it right here.
No, I
You can
guess.
start to see that up there.
Really trouble.
So yeah, opposite, yeah. I don't know how they did that, because it's usually an AP.
Yeah, they did a really bad job of that X-ray.
But that looks like it's starting to develop.
Overlapping thumbs.
That one might be developing, this one might be developing. This one definitely is well on its way. Okay, and you can see some of the other changes, even in the distal joints. Okay, you see some of the changes. It looks like arthritis. But how would you tell the difference? Skin lesions, history of skin, psoriasis. Okay. All right, and then the enteropathic one, this is associated with inflammatory bowel disease. So what are your inflammatory bowel diseases?
Crohn's disease.
Ulcerative colitis and
Crohn's.
Crohn's, okay? And most of these are seronegative, involving the axioskeleton. So it can also be associated with Whipple's. And it can be associated with other bacterial bowel infections and overgrowth. Okay, so think bowel, enteropathic causes, you treat the underlying process. So you're gonna, deal with that and hopefully it goes away. And it looks very similar, it's just your history is going to be different. Okay? Can everybody see the inflammation involving the SI joint on the pelvis film? What looks different? What looks inflamed? What's lit up? Right here. Right there. I know it's a little blurry on the screen. Okay, so you should be able to see. Both are really evolved. This one's more prominent to me. And so, there's your SIJ, it's a spondyloarthropathy. Now, look at the spine, look at the MR of the spine. And what do you see? Okay, I'll tell you what I see. I see little punched out lesions here, here. Okay, and then if you look at the spinous processes, there's a lot of inflammation going on involving even the ligaments that are attaching the posterior spinous processes. And remember, you start where the ligaments or tendons attach. So here you've got a punched out lesion. Here you've got a punched out lesion. Looks somewhat lytic. But look at, okay, your posterior spinous processes here. That's where those ligaments run up and down the spine and attach. And it's at the end points, the attachment points, where you get that. If you change the weighting of the MR image, you can really see those reactive spots in the vertebrae. Okay. Oops. So if you change the weighting, you can see those reactive spots in the vertebrae. Okay. All right, and then Lyme. Okay, Lyme disease, as you know, just finished your infectious disease. Migratory polyarthralgias can have arthritis, lead to arthritis, and it can actually let's see, where am I with this? Arthritis is associated with Lyme disease. And yes, your differential is going to include all of these things. The arthritis usually occurs after the initial infection. Yours, again, it's a reactive arthritis, so your synovial fluid is going to be sterile. It's not gonna grow anything, you're not gonna see anything on gram stain, other than maybe some white cells. And it's both T cells and B cells that react and cause joint inflammation. So you will see both. So this involves both T cells and B cells, which is a little bit than, say, Reiter's syndrome, or even your psoriatic arthritis. This has to do, and yeah, can you tell your patient comes in? No, this may be your patient's presentation. Lyme disease can present in so many ways. And yes, you can have a red hot swollen knee. Can you tell that that's not a septic joint, or it's not gout or anything? No, you can't tell by looking at your patient. Now, if your patient has a history of a tick bite, can you definitely rule that out? No, you might have to stick a needle in it, you can also rule that out, send it to the lab, and prove that it's not a septic joint. That's why you do the procedures. Tapping the knee is very satisfying, by the way. And so the MRI here. Okay. If you look in here, there's a lot of reactive stuff going on, for lack of a better word. And you can see all the fluid. And that is causing this knee swelling. But there's a lot of reactive stuff in that knee. And that's your reactive arthropathy. But if you look and you track it up, look where it's affecting, especially. So remember, your reactive arthropathies, your seronegative spondyloarthropathies often start where the ligaments or tendons attach to the bone. And this is that quadriceps tendon that attaches to the superior end of your patella. And you can see all that inflammation there. All right, and then the one next to it is your C-spine, and it's actually showing some increased uptake or inflammatory changes in your C1, C2 through C4 areas. So you'll see some inflammatory changes there. And that's really it.